Hello, and welcome to AMCI's YouTube course. I'm Mrs. J. I'm the curriculum director here at AMCI, and I am over the moon excited about today. And I just want to acknowledge that I know each of you comes to this course from a different place. Some of you have already been self studying, and others may be enrolled in other courses, and some of you are just beginning the journey of self study. No matter where you are in this process, I want you to know that what you're doing is commendable. You're investing in yourself, your future, and that is something to be proud of. So make sure that you be proud. And what we want to do here at AMCI, we want to support you in your journey. So before I go any further, I want you to meet my amazing team.
Hello everyone, I'm Sandeep, AMCI Curriculum Director, and I'm excited to welcome you all to the AMCI YouTube course. This is a great opportunity to learn, practice, and grow. So make the most of it, stay engaged, and enjoy the course.
Hello, coders. Welcome to the YouTube course. My name is Ms. Mills. I teach medical terminology and anatomy. And I want to remind you that you said you were going to do this and you're doing it on purpose. So you might as well do it. See it through. Have an awesome session. And again, welcome.
Hi everyone, I'm Miss Dolly. It's great to see you all here and welcome to the AMCI YouTube course.
Hi coders, I'm Miss Eva. Welcome to AMCI's YouTube course. Glad to see you here.
Hi, everybody. I'm Miss Bianca, and I am an AMCI instructor. And I just wanted to say welcome to the YouTube course. And I'm excited to have you here. And I hope you guys all find it valuable. And I'll be talking to you guys all in the comments.
Thank you, team. All right, so now from here on out, I'll be referring to you as coders. Why not, right? Let's claim it. Okay, so please say hello to the AMCI instructional interns. They should be in the chat and have a blue badge that says AMCI intern. And they are in that chat. They're ready to help. So go ahead, say hello. Well, many of you know that this course is a 16-week course structured to break down coding concepts, coding guidelines into these digestible nuggets. You'll get step-by-step instruction, you'll get hands-on practice, and by default, you're going to get some of AMCI's proven study techniques. So that's good. And by the end of this course, you will be ready to prep for the medical coding exams. And you might say, Mrs. Shea, what are you talking about? Isn't this a prep course? No, it isn't. It is an instructional course. We are going to give you what you need, the structure, so you can prep, and so you will have optimal chances of not just having success on the exam, but success after the exam. We're going to talk about that in a moment. But before you, on your screen, this is the YouTube course right from the website. And I'll give you the link. You'll get the link by the end of the class. But here you can find everything about the course, specifically the textbooks that you need, how to purchase your texts, and your syllabus. Your syllabus is everything. We're going to look at it at the end. And at a glance, you can see what we'll be discussing the first 8 weeks and then weeks 9 to 16. All right? So everything you need is on this website. So you might want to lock it in. Since we've announced that we're going to have this course on YouTube, we've been getting a ton of questions. Now, we can't answer all of them, but I've compiled a list and I'm going to try and answer some of them. And each week, if applicable, I'll answer them. So if you have questions, definitely submit them on the survey. At the end, you'll be given a link for the survey. Also, the survey will also be available on the website. So I'll just say this. If you want to know where is everything, go to the AMCI website. There's a link for the YouTube course. You can find everything there. And a lot of times it's in the description of the video that you're watching on YouTube as well. But everything is on the website. That's question number 1 and answered. All right, so here are the most common questions. Why are we offering this YouTube course? How come Monday nights are not live? What is the difference between the YouTube course and the AMCI paid course? Will we be ready to test at the end of this course? Meaning, will you be ready for your certification? And I think we have one more. And that's, do I have to become a YouTube member to participate in this course? I'm going to answer that question now. I'm going to answer 5 first. All right, so you probably know, or you don't, that YouTube has memberships. It gives, different creators an opportunity to have members. So the question, do I need to become an AMCI member on the YouTube channel to participate in this course? And the answer is no. No, you do not. But we do have a membership, and what is the advantage? The advantage is we have a Discord group. Now, the Discord is where you can kind of interface with other students who are taking this course. And also, if we have anything to share, we're going to share it in the Discord. Now, I tried to do it, open up the Discord for free, but I was cautioned against it because of the bots and the spamming. So we can't make it free, but it is $2.99 a month if you choose. Also, membership has 3 different levels: bronze, silver, and gold. Of course, gold, you get more stuff. However, silver and up, you can participate in the exam prep content. Again, this is not an exam prep course. There's a lot of exam prep courses out there that kind of present themselves as a full course, but they may not know it. They're exam prep. So here we're going to teach you the nitty gritty. We're going to teach you the guidelines and nuances. All right, I digress. I'm back. All right, so if you go to the website and you click join, you can join and become a member. That's it. It is not mandatory. All right. Here's another question. Why are we offering the free YouTube course? Why? Well, at AMCI, we believe in training world-class medical coders who are not just exam ready. When I say exam ready, multiple choice exam ready, but job ready. This free course is a part of our commitment to elevating the standards in the medical coding industry. This is our way of giving back to the community. And since 2015, we've done just that. That is how we've gotten our start. And also in 2015, we launched a annotation technique for CPT. And it just so happens that this is AMCI's 10th year anniversary, it's the annotation technique called Chun's 10th year anniversary. And I think that offering a fully comprehensive 16-week certification course is a good way to say thank you. All right, so that's pretty much it. And I do have other reasons, which I'll talk about in the subsequent classes, because we've got stuff to do. We got a lot of stuff to talk about, right? All right, so another question. How come you don't teach live? How come your lessons or lectures are pre-recorded? I think the best way to answer this question is I once had a student tell me the same thing. Well, she questioned why we don't teach, and she said, I don't learn as well when the instruction is recorded. And I said to her, are you aware that I, your instructor, am in the chat? I am right there answering your questions in real time. And if I don't know the right answer right away, I can research it really quickly and provide you with an accurate response. Even if I can't get that question answered immediately, at least I can take note of it and follow up with that student. Now, I said to her, now, if I were teaching live, do you think I'd be able to answer your questions in the comment? Could I stop and engage you directly while keeping the lessons going for everyone? Can I do that? Heck no, I can't do that. Some instructors may be able to. However, there are other reasons why we record. Errors can be edited, explanations can be refined, and the information is that much more precise. In other words, you're getting the best version of me. You are. So I say, which is better? Would you rather have me delivering content that's precise and not as error-ridden? I'm not going to say I'm not going to make any mistakes, but I make fewer when it's recorded. And would you like me to be in the chat with you? Go ahead and say hello to me. I'm the one that's saying, you rock, coders, you rock. I'm cheering you on. So go ahead and ask me questions. I cannot do this if this isn't recorded. All right, so hopefully I've answered that question. Now here's another question. What is the difference between the YouTube course and the AMCI paid course, the MCDC course? Even AI asked me that. Like, what is the difference? Like, what is, not necessarily what is the difference. They really want to ask, what are you getting from this? Well, I already told you what I'm getting from it. AMCI, by nature, we are givers. That is how we started, and that is how we're going to always be. And that, I think, is the premise of our success. Not really caring about profiting, but more importantly, the profession. All right, so what's the difference? Well, of course, the cost. The YouTube course is free. AMCI's MCDC course, and we call that medical coding dual course, it's paid. Also, the duration is different. The YouTube course is 16 weeks. AMCI course is, you can take up to 24 months, so you can relax. You don't have to rush through. Certificate of completion, you both get certificates of completion. However, the YouTube course is not valid for the 80 credit hours, and the MCDC course is. And when I say 80 credit hours, that's the AAPC requirement if you're sitting for the CPC. But if you're sitting for the CCS-P, you don't need an 80 credit hour. Just saying. Also, group studies or study groups. The YouTube course doesn't have them. The AMCI MCDC course has them twice weekly. Next, instructor interaction. Well, the YouTube course, you can interact with your instructors on Monday in the chat. And the AMCI MCDC course students, they can interact daily. Typically, Monday through Friday, they get a 24-hour response, and they can interact in real time in those group studies. Exam prep integration. For the most part, we didn't integrate exam prep in this YouTube course. However, you'll see exam prep in that membership group on the YouTube channel, the Discord. That's where you'll see exam prep. But this course does not have exam prep. AMCI's MCDC course does. Boot camp, there's no boot camp. However, the MCDC has a boot camp. A learning management system. This course has none. Learning management is just how your learning is managed. I've done the best I could to manage it for you, but the MCDC course has a formal learning management system. It's pretty nice too. Also, job assistance. There's no job assistance with the YouTube course. There is job assistance with the AMCI MCDC course. Internships, externships come with the MCDC course. CPT Chun integration. What is that? That's our annotation technique. A lot of people think it's gold when you're taking your your medical coding exams, all three, CPC, CCS-P, and CCS. It's gold. So in other words, we've integrated the instructor's Chun pages in the course. Also, course verification. We're noticing employers wanting students to be able to verify that they've attended a course. And this is a course that employers are taking seriously. But we cannot do it if you're a YouTube course. We can do it with the MCDC course. But I want to say you will get a certificate of completion at the end, and you can say that you were a part of the AMCI course. And that, if they need us to validate it, we can't because we don't know. We don't know. All right, so CCS exam specific instruction. No, there is no instruction, specific instruction. When I'm saying specific, I'm talking about that exam, those 5 domains. It's not in this course. Now, the basics, the professional side of it, yes. But for the most part, no. But it is in the MCDC course. And again, the AMCI validation of completion, we don't do it for YouTube course. We do it for the AMCI MCDC course. And finally, test taking anxiety classes. We have a whole course for people who deal with anxiety, and that's what we do at AMCI. All right, I got another question I want to answer. Will we be ready to test at the end of this course? No, you'll be ready to exam prep. At the end of the 16 weeks, you'll be ready to exam prep. You can join the Discord, silver or gold, for exam prep, but you don't need it because we are going to tell you exactly what you need to do at the end of the 16 weeks. So don't you worry. And if you all say, hey, I have to spend more, no, you don't. No, you don't. You do not need to join the membership group on YouTube. It's just a preference for some people, okay? You can do this. I'm going to do my very best, and hopefully it will be obvious. You'll know. All right, let's continue. So I've answered some of the most common questions, and hopefully that if you had that question, it was answered for you. If not, if you have more, we do have a survey. Go ahead and fill out that survey at the end. We'll give it to you and let us know. All right, what are the required texts? You all probably already know the required text, but I will review. All right, these are the required texts for this 16-week course. You have the ICD-10-CM 2025. We recommend Optum, Bucks, step by step. 2023 through 2025 is good, but 2025 is best. And the reason it's, if you're tight and you want to save money, then get a older version. But if you can, I recommend the 2025 because Carol Bucks did update the evaluation and management section. So I do recommend it, but it's not that much. It really isn't. So we got you if you want to save money. All right, the MCG manual 2024 or 2025. The difference, 2025 has the most up-to-date guidelines. However, we're going to give you the guidelines in the form of a handout. So if you want to make corrections as you go, it is more economical. Also, the CPT 2025, HCPCS Level 2 2025. These are the recommended texts. Also, for the first 8 weeks, if you're on a budget and you just kind of want to buy as you go, you're going to need the ICD-10-CM expert. Well, we recommend this expert for hospital by Optum. Why? Because if you decide to take the CCS after the CPC or CCS-P, this is the book you're going to need. If your end game is CCS, that's why you're here. I recommend this book because of the indicators in the book. No other book has these types of indicators, and they give you an advantage when taking the exam. And it's an economical book. You don't have to purchase 2 books. This book, this 2025 manual will last you until April 30th, 2026. Yes. So it is economical. All right, and you're step-by-step in the MCG manual. Now, we have to cite our copyright. CPT is copyright 2025 AMA. All rights are reserved. Keyword concept, FTR, CHUN, AMCI Fab 7, AMCI, ICD-10-CM Flip Tap, and MCG are trademarks of AMCI. The credentials, CPC, CRC, COC, CPMA, CPB, CPPM, CPCO, and more are owned by AAPC. The CCA, CCS, CCS-P, RHIA, RHIT are owned by AHIMA, and AMCI does not own the rights to these credentials. This is week 1, and week 1, we will review ICD-10-CM basics. We're going to take a look at some general coding guidelines and or conventions, and you pretty much should be familiar. You probably already know that the guidelines are organized in 4 sections. Section 1, that's pretty much your general coding guidelines, your conventions, and your chapter specific guidelines. Sections 2 and 3 pertain to principal diagnosis selection for inpatient. That's section 2, and section 3 are the guidelines for reporting additional diagnoses for inpatient settings. However, section 4 guidelines, these are diagnostic coding and reporting guidelines for outpatient. So sections 1 and 4, this is our focus for the next 8 weeks. Let's take a look at the ICD-10-CM official guidelines for coding and reporting. As you can see, these are updated in October. Every October, they typically come out with the new guidance. These are from October 1st, 2024, and they're good until September 30th, 2025. All right, so CMS publishes these guidelines, and if you just scroll down and we get to the table of contents, you can easily see how the guidelines are laid out. And, this is pretty much how we're going to study for the next 8 weeks. But today, we're going to talk about Section 1 Guidelines A. And A are the conventions. And you can see that there are 19 conventions. We're not going to talk about all of them. But B guidelines are general guidelines, and there are 19, a little more than 19, well, 19 with a little extra. Then after today, starting next week, we'll begin C guidelines, and these are chapter specific guidelines. And there are 22 chapters, and we'll take a look at all of them. Then we're going to bypass section 2, section 3, and go right to section 4. And we're going to study these guidelines on how to select the first listed code. So we have a lot to unpack for the next 8 weeks. Let's begin our instruction with a review of Section 1 guidelines. There are 3 parts to Section 1. You have A guidelines, B guidelines, and C. Let's take a look. All right, so we've said earlier that Section 1A guidelines are conventions, B guidelines are general coding guidelines, and C are chapter-specific coding guidelines. Now, we're not going to review all of the guidelines. I believe they are addressed in the previous lectures or the prerequisites that we've given. Now, I want to know what you already know. Well, you should already know the accurate coding process. You locate the diagnosis in the index, you verify the code in the tabular list, you review all guidelines, and you code to the highest level of specificity. You also should know that the alphabetic index is where you go first, and they're organized alphabetically, and they're located in the front of the book. And that's kind of unusual, right? So you should know all about the alphabetic index and the tabular list. Remember, those are the color pages in the middle. You also should have learned about specificity. The longer the code, the more specific it is. You also should have learned what a category code is. That's a 3-character code, or it's the boss. You should have learned that category specific codes or subcategory codes are between 4 and 6 characters long, and codes are 6 to 7 characters long. And again, the longer the code, the more specific it is. You also should have learned about integral conditions. Pretty much, you don't code conditions that are integral to a disease or illness. You just don't, in most cases. But we're going to learn starting next week that there are some exclusions to the rule. You should have reviewed multiple coding guidance when it comes to coding etiologies and manifestations, as well as proper sequencing of codes. You also should have learned about acute and chronic conditions. In most cases, the acute or the cute one goes first. Also, you should have learned about combination codes. When you have more than one condition and there's a combination code, you use it. Also, you should have learned about late effects or sequelas. You also should have reviewed when you have the same diagnosis code in a record, what to do. What is the rule? You should have learned about laterality. 1 means right, 2 left, and 3 means bilateral. And you also, in addition to laterality, you should have learned about non-specific codes as well as not elsewhere classifiable. Now, these are pretty much some of the topics that you should have covered in your instruction and more. As you can see, when we looked at the guideline, there was roughly 40 guidelines in the A and B section. 19 were conventions and 19 were specific coding guidelines. But I'm pointing these out just as a way to kind of gauge your understanding. Some of them are more easy to absorb, and others require a little more instruction. But I've found that the includes and excludes notes, Sequela, and selecting the first listed code were a little more challenging and requires a little more instruction. So today we will have a deep dive in the following: Sequela, includes and excludes notes, and selecting the first listed code. Let's begin with Sequela. Okay, coders, who can tell me what this is? What is this? What do all of these movies have in common? If you said they have sequels, all of these movies have sequels. And what is a sequel? Well, that means that there had to be a movie, a first movie, and the second movie or third movie is the sequel. And just like a sequel, a movie sequel, a sequela can only occur after the initial or first illness or injury. I'm going to let that marinate. When coding sequela and late effects, there are some things that you need to be aware of. The acute phase. The acute phase is the phase or the original illness or injury. So let's just leave it brief. Acute phase is the original illness or injury. I'm going to let that marinade. The residual phase or the residual condition is the condition that exists today that resulted from the acute phase. And it's the condition that requires treatment. It is the sequela. And also, when you're coding these sequelas, you're going to need to know what a sequela code is. So, in general, a sequela is a residual condition left after the acute phase of an illness or injury that has resolved. And these conditions require special coding considerations. And often people get confused coding these sequelas, and that's why it's one of our target subjects for today. All right, so just know the difference between an acute phase, residual condition, and that's actually your sequela and your sequela code. Now, I have a scenario for you. Now, coders, I want to give you some context. Meet Betty. Betty is a college student. She fractured her leg. She was it was Halloween. She was on a hayride and she decided to stand up while the cart was moving and she fell off, broke her leg. Meet Betty 10 years later. Betty has a limp. So Betty 10 years ago, that broken leg would be considered the acute injury, the acute phase. However, today, that limp is the sequela. Now remember, the acute phase is the condition that comes first, and the sequela comes after the acute phase of an illness or injury. And another name for sequela is late effect. I'm going to let that marinate. And the guideline that we will be referencing will be B, General Coding Guidelines of ICD-10-CM. So guideline B, General Coding Guidelines 10, sequela or late effects. And let's take a look at it. We're going to bring it up really clear. So a sequela is the residual effect or the condition produced after the acute phase of an illness or injury has terminated. There is no time limit on a sequela code. The residual may be apparent early, such as a cerebral infarction or stroke, or it may occur months or years later, such as due to a previous injury, like Betty. Some examples of sequela are scar formation or contracture resulting from a burn, deviated nasal septum due to nasal fracture, infertility due to tubal occlusion from old tuberculosis. Now, this is what we need. We need to know what are the guidelines to code sequela. And here it is. Generally requires 2 codes and it's sequenced in the following order. First, the condition or nature of the sequela is sequenced first. Second, the sequela code is sequenced. And that makes sense. How could you code an acute condition 10 years later? I'm going to let that marinate, and I also think it's going to make sense in a moment. All right, so we have our guidelines on the left, but really the guideline says that it requires 2 codes, the condition or nature of the sequela first, and the sequela code is sequenced second. Remember earlier I said we need to define what a sequela code is because it's going to come second, right? All right, so the condition is typically your reason for the encounter. We're going to sequence in first. So if Betty comes to the doctor's office today, the condition that she has will be sequenced first. Now, what is a sequela code? A sequela code is that acute injury with the 7th character S. So it will be that acute injury with a 7th character S. S is for sequela, and it will look like this. R26.89 will be for the limp, and S82.90XS for the sequela. So a sequela code is an acute code with an S. in this case and most cases. All right, coders, I have an exercise. All right, so this will be our very first exercise. Type your answers in the chat. There are 2 questions. I want you to tell me what the Sequela is and what is the Sequela code. Not necessarily, I'm not asking you to code it. I just want to know which illnesses, which one will be the Sequela and which will be the code. Byron was involved in a motor vehicle accident 3 years prior where he has sustained a fracture of the lower left leg. Today, he presents with pain of the lower left leg. The physician indicates that the pain is related to the previous injury. Okay, coders, what is the Sequela and what is the Sequela code? So which illness or injury would be the Sequela and which will be the Sequela code? Please type your answers in the chat. I'll give you a moment or 2. I know this is the first exercise, so it's going to take us a moment to get adjusted. All right. So what did you say? Well, first, we have pain in the lower left leg, and the patient also had a previous fracture of the lower left leg. So the Sequela is pain in the lower left leg. The Sequela is what is happening today. And the Sequela code, this is what happened before, right? And we're going to code that Sequela first, and we're going to code the Sequela code second. And what happened before? Well, the fracture of the lower left leg is what happened before. And anytime you have a Sequela, you have to look up in the alphabetic index, sequelae. Yeah, that's plural. All right, so we're going to do that. We're going to look this up together. We're going to look under sequelae, fracture of the lower left leg. So I want to clarify this. I want to clarify it. Anytime you have a Sequela and the doctor says it's related to a previous injury, we're going to have to look up that previous injury in the alphabetic index, and we're going to look under sequelae. All right, so we know this patient had a fracture of a lower left leg. We want to find the Sequela code for that fracture. All right, so we're going to look under sequelae of fracture. And anytime you're learning it today, you don't have to do this next time. Anytime you have a fracture, you are directed to code to the injury with the 7th character S. So anytime you have a fracture sequela, just code the initial injury with the 7th character S. So let's go ahead and do it. All right, so I'm going to look up fracture, traumatic, leg, lower, and it directs me to S82.9. And yeah, I see that checkbox. It says, hey, you're going to have to check that box, right? This box, all right? So I'm going to the S82 category. I'm going to put my pointer up here so you can see it. Fracture of lower leg, including ankle. And then there's a note, and they're telling you how to code fractures, displaced, open, closed, etc. These are some guidelines. We have includes notes, excludes 1, excludes 2. And this is the good stuff, this 7th character. We like to call it 7th character extender box. And I'm looking for my S, Sequela. All right, Now I'm going to go and I'm going to code this out. I'm going to look for S82.9 subcategory. There it is, unspecified fracture of the lower leg. And we are coding for the left lower leg, S82.92. That is our code. Now we do know that we have to code the sequela. We're going to have to elongate this code. We're going to put an X after the 2 to make it 7 characters. So the code will be S82.92XS. This is our Sequela code for this encounter. Now, this is what it would look like if you coded it out in the real world. We'll sequence the pain in the lower left leg first, followed by the Sequela code. M79.662, pain in the lower left leg, and our Sequela code will be sequenced second, as per the guidelines. Okay, coders, how did you do? Did you get it? I know I didn't tell you to code it. I wanted you to see it. Now the next one, let's see what you can do. Oh, by the way, if you got that correct, outstanding. And if you learned something, which I think many of you have, say, aha! Go ahead and shout those ahas out in the chat. Aha! I want to know. Remember, I'm in the chat. I'm in there with you. Exercise number 2. Of the following, which answer best describes the encounter? A. M25.611, L90.50, T22.051A. B. L90.50, T22.051A. C. T22.051S, L90.50. D. L90.50, T22.051S. Maria, a 30-year-old woman, presents or visits the doctor's office due to a limited range of motion in her right arm following a severe burn injury 6 months ago. The physician diagnoses the patient with scar contracture of the right arm. To address the issue, the doctor recommends a series of physical therapy sessions and refers her to a specialist for possible surgical intervention. Okay, coders, can you answer this question? And can you answer it without looking up the code in the book? And for those of you that have already answered, way to go. For those of you that need a little more time, just continue. And I'm going to speak to the people that are finished. Well, just so you know, at AMCI, we read questions the following way. We read the last question, then the answers, then we read the scenario. We do it this way so that you can first understand what you're being asked to do. Usually it's that last question. And then we tell you to read the answers first because our students already know what they have some skill and they can look at the answers and almost tell what is going on. And if you have that skill, and some of you probably do, because if you've learned to recognize the categories on site, you might be able to tell some things. Like on site, you would know that this first code is from the musculoskeletal section. You'll also know that the second code is a skin condition. Is scar contracture a skin condition? You better believe it is. Why is this patient here? Well, this patient's here for that scar contracture, and they're being treated for it And the physician even recommends physical therapy for that condition. So that is why the patient is here. And that T22 code, we know this is an injury code, but we also know that that seventh character is an A. And that A tells us that this is an acute injury, and we do not code for an acute injury in the setting of a sequela. In fact, it's impossible. How could you have an acute injury, and I'm saying injury, in you could have an acute phase and a sequela in the same setting, and typically you'll see that whenever you're having a stroke, you could see the residual effects, but not an accident, a physical accident. Okay, not this accident. You can't have an acute accident and a sequela in the same setting. You just don't see that. So we know that we're coding for that contracture first. So that first code needs to be an L, right? Right. The second code needs to have the S, seventh character extender for sequela. How do we know? Because the guideline tells us to. We have to have that sequela code last. All right? So first, the condition or the nature of the sequela, your injury, or your condition, sorry, not your injury, your condition, the reason you're there is sequence first, followed by your sequela code. And D is your answer. If you said D, way to go, way to go, way to go. For some of you. All right, so we're going to leave this subject and hopefully you gained some things. Hopefully you learned that the residual condition, the condition that you have that resulted from that old injury, is your sequela. You're going to sequence it first. And then the cause of the sequela, that injury, that old injury, is your sequela code. You're going to sequence it second. And here's a tip: never report the acute phase with a sequela code when there's an injury going on. All right, so here's an example. Patient has left ankle pain due to a fracture that occurred 10 weeks ago. You're going to code first your pain, your ankle pain, then the old fracture with seventh character S. Okay, coders, I think we're ready to move on. Let's do it. Includes and excludes notes. All right, coders, let me know if I want to know right now, how do you feel about includes and excludes notes? Do you have it down pat? If you have it down pat, show me some claps in the chat. Let me know. If you need more, go ahead and say, I need more, more, more. I'll take a moment. All right, let's begin. Okay, so now let's talk about includes notes first. And I want to point out I did adjust my mic, so if the sound is different, I do apologize. I hope it's better and more clear. All right, coders, so first, convention. It's part A, convention, part A of the guidelines. Part A of section 1 guidelines, conventions. First, includes notes. Guideline number 10 includes notes, and it reads that this note appears immediately under a 3-character code to title to further define or give examples of the content of the category. In other words, if the code is listed under the boss or the category or under the title that says includes, you can code it using that category code. So you can code it. All right, here's the visual. All right, so if the patient has granulomatous enteritis, you can use K50 Crohn's disease or regional enteritis. You can use that code. That's all includes is. It's that simple. All right. Now, let's take a look at Section 1 guidelines, A, conventions. Number 2, excludes notes. There are 2 types of excludes notes. Excludes 1, this is the one that we'll focus on now. A type 1 excludes note is a pure excludes note. It means not coded here. In other words, if it's listed under that excludes 1 note, it means you cannot use that code for that category. All right? So it means do not code. I'm going to let that marinate for a moment. And now I'm going to give you a visual. I want to use diabetes mellitus as an example because it's something that we're used to, especially if you've been coding for a while. All right, so if we are at the BOSS E11 type 2 diabetes mellitus, if you look at the excludes 1 note right here, if any of these diagnoses, if the patient has any of these diagnoses, you may not code from the E11 category. You may not code these diagnoses. You have to code the diagnosis that's listed, right? So if an excludes 1 note is listed under the category in this circumstance, any of these, if the patient has any of these diagnoses, you cannot code using E11. So if a patient has gestational diabetes, you do not use E11. No, you do not code gestational diabetes mellitus using E11. If a patient has type 1 diabetes mellitus, you do not use E11. So it's that simple. It's a pure excludes note. So do not code from the E11 category if a patient has any of these diagnoses. I'm going to let that marinate. Now that we have excludes 1 down, let's take a look at excludes 2. All right, so when you have excludes 2, and this is a type 2 excludes note, this also means not coding here, but they have a condition where you can code, when you can code. All right, so if an excludes note 2 note is listed under that category code, then you may use both the category and the excluded code if the patient has both conditions. So essentially, if the patient has both conditions, code both. If the patient doesn't, then it goes, you cannot code the condition in lieu of the category. All right, I can show you better than I can tell you. But in general, excludes 2 means you can code both conditions as long as the patient has both conditions. Now I'm going to show you. Now here is our visual. And as you can see, we have all 3. We have includes notes, excludes 1, and excludes 2. So this is our review. We have J20, acute bronchitis. If a patient has any of the conditions within the excludes note, you may use J20. So if they have any of these conditions, you can use J20. It's included. Next, excludes one note. If the patient has bronchitis and or tracheobronchitis, you may not use J20 for those conditions. In fact, they give you the codes. So it's a true excludes note. So if the patient has bronchitis, do not use J20. Now, excludes 2 means if the patient has bronchitis and bronchiectasis, J47, you may code both. You may code 2 codes. So you can use J20 along with J47 if the patient has both acute bronchitis with bronchiectasis. You can use J20 if the patient has both acute bronchitis and chronic obstructive asthma. So you have to code both. Code J20 for the acute bronchitis and code J44 for the chronic obstructive asthma. So in general, let's go ahead and clarify everything. Let me get rid of my pointer. Includes means you can code it. Excludes 1 means do not code it. It's pure excludes note. Excludes 2, you can code both conditions as long as the patient has both. And there you go. I hope you got it. Now it's time to practice. All right, so our clipping is right here on the screen, so you don't have to go look this one up. You can get the answer from the screen. And I will not be reading this like we traditionally do because this is not a traditional question. All right, coders. Patient is diagnosed with acute pharyngitis, J02, and chronic pharyngitis, J31.2. Can the coder code both conditions in the same setting? Select the reason why or why not. A, yes, because you sequence the acute condition first. B, no, because the excludes 1 note says you cannot. C, yes, because the excludes 2 note says you can. Or D, no, because it's impossible to have both acute and chronic pharyngitis at the same time. Okay, coders, what say you? What say you? I'll give you a moment. Okay. Well, if you said C, that is the best answer of the 4. You could have said A and been correct, but C is more concise and the guideline and the reason is written. So the patient has acute pharyngitis, J02, also chronic pharyngitis. So let's take a look at acute pharyngitis, J02. And let's look at the notes. And the note, the excludes 2 note, is applicable. It says if the patient has chronic pharyngitis, J31.2, our case, you can code J31.2 with J02 as long as the patient has both conditions. And the patient has both conditions according to the documentation. So that is the answer. And you only code them both if the patient has both conditions. So if the patient only had chronic pharyngitis, you would not code J02. And our patient had both. And yes, A is correct too, but C is the most correct. Way to go, coders. Way to go if you got it correct. If you said A, good job too. That's correct too. But I wanted that reason. All right, we got another exercise. Exercise 2, and you again, the clipping is on the right. Patient has tuberculosis of the inner ear, A1 8.6, and the external ear, A1 8.4. Can you code both conditions? And if so, why? All right, coders, is your answer A, yes, because the excludes 2 note says you can? B, no, because the excludes 2 note says you cannot? Or C, yes, because it's possible to have both inner and external tuberculosis at the same time? Or D, no, because you can't have an inner ear and external ear tuberculosis at the same time? What say you? I'll give you a moment. All right, coders, if you said well, I'm not going to tell you the answer right now, but just to clarify, this patient does have inner ear and external ear tuberculosis. And if we look at the code, A1 8.6, this is a subcategory code. It's not a category code, and an excludes 2 note is right underneath. And we see, let me get rid of this. Tuberculosis of the external ear, A1 8.4. That's our code. And this guideline says that if you have external ear as well as internal ear or inner ear, you may code them both. That is the guidance. So if you said A, yes, because the excludes 2 note says you can, you are correct. And C would not be correct because you are just basically qualifying yourself as the clinician. Now we have a guideline. When a guideline tells you to do it, you can. And remember, coders, if the guideline, if it's not documented, often it doesn't exist. So guidelines rule. The physician's documentation rules, and so too does the guideline. And in this case, we have an excludes 2 note, and that is a guideline. So if you said A, outstanding. All right, we're winding down on our discussion on includes and excludes notes, and we learned that when you have an includes notes, it means you cannot code it. If you have an excludes 1 note, you may not code it. Never. If you have an excludes 2 note, you can code it as long as the patient has both conditions. You can code both codes if the patient has both conditions. And remember, these notes are guidelines, and they are crucial for accurate code selection and application. All right? Okay, so how do you feel, coders? We've completed our discussion on sequelas and includes and excludes notes, and hopefully, coders, you have clarity. And if you do, go ahead and type in the chat. Say aha if you have clarity, or if you already know it. If you already knew it, just say, hey, I already knew it, and that is amazing. And whatever else you want to type in the chat, just go ahead. I can see it. I can see it because I'm in the chat with you, shouting you out. All right, so now it's time to move on to our final subject, and that subject is first listed guidelines. How to select the first listed code. We're going to do it with guidelines. Now, before we get into our discussion about first listed code and selecting the first listed code, I just want to tell you why we need to identify the first listed code. We have to identify the first listed code because CMS, the Social Security Act, and all health carriers, they require us to identify it, right? And pretty much that first listed code is the code that will substantiate medical necessity for that encounter. And that's what's needed to get paid. You have to substantiate medical necessity for the visit. And you will need to identify the first listed code when you have multiple conditions. If there's only one condition, then you know, right? But when you have multiple, you must list one first, and that first listed code must substantiate medical necessity for that visit. In other words, that diagnosis that's listed first should be the reason for that encounter. And if you really wanted to know which guideline, it's 1862 A1A of the Social Security Act that says it. And it says Medicare is only going to cover services that are reasonable and medically necessary for the diagnosis or treatment of an illness or injury. So just to kind of summarize things, when you have multiple diagnoses, that diagnosis that's first listed will justify or should justify that visit. It will substantiate medical necessity for the treatment. So if a patient has a diagnosis of breast cancer, then breast cancer will substantiate that mastectomy. If a patient has a diagnosis of obesity, that will substantiate medical necessity for a gastric bypass. A bunion will substantiate medical necessity for a bunionectomy. So, the code that you list first will most substantiate the treatment, and the doctor will most likely be reimbursed. Now, when you have a circumstance and there's no treatment, let's just say it's a regular visit, and there are multiple diagnoses, you still have to list one first. So generally, the diagnosis that was chiefly treated or addressed will be first listed. So if the patient has all of these diagnoses, hypertension, sinusitis, detached retina, arthritis, then the one that the doctor addressed the most often will be first listed. But if the documentation says, hey, the patient came in specifically for a detached retina, then that might be first listed. But it's going to be up to you, coders, to review the documentation and make that determination. And also, you will need to use guidelines. Guidelines may help you a lot when identifying the first listed code. And when it comes to selecting the first listed code, you should understand these key facts. These codes, ICD-10-CM, are used for professional coding, that's coding for the doctors, outpatient facility coding, that's coding for the resources for that facility, and inpatient facility. This too is coding for resources for inpatient facilities. But if we take a look at professional and outpatient facility, they're pretty similar, right? So we know professional coders or Yeah, professional coders code for professionals like doctors or other qualified healthcare practitioners. Also, they use all of the code sets, but primarily their focus is the CPT and HCPCS level 2 codes. These are the money drivers. This is what pays the bills, CPT and HCPCS level 2. Also, their payments are based on RVUs, and they only code things that are confirmed. They don't code for things unconfirmed. And the main or primary diagnosis is called first listed. So if you look at outpatient facilities, they're coding for facilities, the resources, not the people, but the resources used for that encounter. And their money drivers are just like professional coding, CPT and HCPCS level 2, but we do use ICD-10-CM codes to substantiate medical necessity for that treatment. Now, the only major difference between outpatient facilities and professional coding, the payments are based on APCs or ambulatory payment classifications. We're not going to get into that, but if you're studying for the CCS, you will learn what APCs are. Also, they do only code for things that are confirmed. They do not code for things that are unconfirmed or not confirmed. And the main or primary diagnosis is called first listed. So the only difference between the two is that their payments are how they calculate payments. All right. Now, just remember your first listed code selection applies only to outpatient facility or professional coding. And just so you know, facilities call their primary code principal diagnosis. Now, just so you know, to kind of sum things up, medical necessity is key. When selecting that first listed code, medical necessity. Of course, your first listed code has to justify the treatment. Also, that documentation has to support that first listed code selection, and make sure you code to the highest level of specificity. And finally, guidelines rule. Guidelines rule. Now, speaking of guidelines, let's review Section 4 guidelines, and these Section 4 guidelines instruct on how to select the first listed code. Specifically, it tells you, see my little orange line? It says that this is for coding and reporting hospital-based outpatient services and provider-based office visits. This tells you it's for providers and outpatient facilities. Also, it breaks down key areas that you may encounter when trying to select the first listed code. Now, let's take a look at these guidelines, Section 4 guidelines, from the perspective of the MCG manual. All right, I'm using the 2025 MCG manual, and this is the E version. So essentially on the left-hand side, I can see my table of contents, and I'm going to locate selection of the first listed code in its outpatient table. And in the middle of the screen here, hopefully, I don't know if you can see my pointer. I think you can. All right, so these are the circumstances under this topic heading that you may encounter when trying to select the first listed code. If you have signs and symptoms, columns 2 and 3 tell you what to do. If this is an outpatient surgery, which code do you need to select as first listed? Columns 2 and 3 tell you. If it's observation stay, Chronic diseases, coexisting diagnoses, what to do, diagnostic procedures, therapeutic services, preoperative evaluations, ambulatory surgery, general medical exam with abnormal findings, what to do. And then if you go down further, we have another table that's a little more, we have an official table that we use. Like it's a quick reference tool, but this table is a new table for 2025. We have the older one too. It's at the front of the handbook. It's the very first or second page. You can find all of the charts, but this table is read horizontally and pretty much what to do. So it's a good read. It's an easy reference tool, and we're going to use it now, but we're going to use the older chart. All right, this is the chief reason for the encounter chart, or the first listed code chart. And we've broken it down into 10 categories or columns. And we're going to instruct you to use this chart by determining which circumstance applies to your situation or your documentation. So if you have a situation where you have all these signs and symptoms, you need to visit 1 to know what to do. If you have signs and symptoms, you can list them first as long as there's no diagnoses, no related diagnoses present. But generally, don't code signs and symptoms integral to or clinically related or integral to a disease. Don't do it. When you have outpatient surgery, code the chief reason for the surgery as the first listed code. And these are general guidelines. Remember, coders, these are general. There could be specific guidance that will take precedence. Always be aware of that. Number 3, if the patient's in observation, let's say they're admitted to observation for a medical condition. If it's a medical condition, the medical condition will be first listed. However, if a patient had outpatient surgery and they were admitted into observation for a complication, then the reason for the surgery will be first listed. Chronic diseases. Chronic diseases can be reported as many times as the patient receives treatment for them during that encounter. Number 5, and I kind of think this number 5, this coexisting conditions, it's kind of used more because you are directed to code all documented conditions that coexist at the time of the visit. So the doctor doesn't even have to be treating that condition. It just has to be present. The doctor just had to mention it. All right. And remember, do not code any resolved conditions unless it's pertinent to the encounter. And if it's pertinent to the encounter, go ahead and use history codes. Number 6, if you have diagnostic and therapeutic services, code as first listed the chief reason for the encounter, and code additionally all coexisting diagnoses. Now, the exception is if the encounter is for chemo radiation therapy. Number 7, uncertain diagnoses. Do not code them. Uncertain diagnoses such as rule out, likely, suspected, probable, etc. Do not code them unless there is a specific coding guideline that takes precedence. And I know off the top of my head, next week you're going to learn about HIV/AIDS, and that guideline supersedes or trumps this guideline, number 7. Number 8, preoperative evaluations. When a patient is coming into that encounter and they're having surgery, your first listed code must come from the Z01.81 subcategory, and you have to sequence second the reason for the surgery. Number 9, in the setting of a preoperative diagnosis and the postoperative diagnosis, always code the postoperative diagnosis first. And finally, When you have a medical exam with abnormal findings, Z00.00, Z00.12 should be your first listed code. So a patient comes in for a routine or annual physical. You're going to list your annual physical first, followed by those abnormal findings. Let's say the doctor found HIV at that encounter. Yes, you're going to have to code the reason for the encounter first and the HIV second. All right. When there is routine lab or radiological testing with no diagnosis, then you use Z01.89. Now, if that diagnostic test renders a diagnosis, then go ahead and code the diagnosis found. However, remember, don't code the related signs and symptoms. So often when you go in for those routine labs, you're going to sequence first your Z01.89 and you're going to sequence subsequently those signs and symptoms. If they find a diagnosis, just code that diagnosis. Encoders, these are your general guidelines for selection of the first listed code. Now we're going to use this chart and we're going to solve some scenarios. But I should mention that this chart does not have all of the guidelines and the full guidelines. So this is just a reference tool. And for full guidance, visit the guidelines in your ICD-10-CM in section 4, or you can look at it in the MCG Manual 2025. Now let's review how to select a first listed code the AMCI way. Step 1, inventory. You're going to need to write down all diagnoses, signs, and symptoms, and procedures too. Sometimes you'll need procedures that are pertinent to your purpose. So a lot of times you don't need them, and if they are pertinent, write it down. Step 2, select your first listed code and make sure you use your chart. Yeah, we're going to use a chart as we're learning, and think of that chart as training wheels. Use it until you don't need it. All right. Step 3, apply all guidelines. And step 4, knock it out the park. Coders, you can do this. All right. The first one is relatively, straightforward, but, it gets a little more involved and I will walk you through the way, but you will be expected to answer the questions. I will give you time and let's do it. You can and you will. All right, coders, I'm going to need you to type your answers in the chat, and you don't have to provide the code. So you don't have to look up the code, but just write the diagnosis such as hypertension, diabetes, etc. And don't forget the instructions. First, inventory. Second, select your first listed code. If you have the chart, go ahead and do it, use it. If you don't, it's okay. And third, apply all guidelines. Now, don't forget, type your answers in the chat. Walter, a 57-year-old small business owner, arrived at his primary care appointment with complaints of unexplained weight gain, swelling of the limbs, and exhaustion. The physician diagnosed Walter with morbid obesity. Okay, coders, what is the patient's first listed diagnosis? So I'm going to ask Ace the alligator. This is AMCI Ace alligator to kind of, count down for us. So when he is finished like that, then you will, that's when we will continue. So I don't think you need much time for this one. So let me walk you through it. Okay, so if you want to go ahead, put your answers in the chat. If you just want to watch the demonstration, thank you. It is my pleasure. All right, so the first step is what? We have to inventory. Inventory all diagnoses, signs, and symptoms. And you get that information from the documentation, right? So, weight gain, swelling of the limbs, exhaustion. And the doctor diagnosed the patient with morbid obesity. So, what is our goal? Our goal is to identify of these four, what is the first listed diagnosis? Or what is the chief reason for the encounter, right? So if I go to number one, because I see a ton of signs and symptoms, and signs and symptoms are not to be coded if they are integral or clinically related to a diagnosis on the chart. So we see there's only one diagnosis on the chart, that's morbid obesity. And we have the following signs and symptoms of weight gain, swelling of the limbs, and exhaustion. So I have to ask myself, are these signs and symptoms integral to morbid obesity? And if I can say yes, then we need to get rid of it. So I'm saying yes, that weight gain is integral, swelling of limbs is integral, and so too is exhaustion. With the extra weight, you can become exhausted. So that leads me to morbid obesity is the first listed code. It is the reason for the encounter. Now, you might say, oh, that was simple. Yeah, it was. But you know what it should have done? It should have told you that although I know that morbid obesity is the reason for the encounter, or I think, but you have factual information because these are predicated. This chart is not doesn't cover all of the guidelines, but it's based on a guideline. So that's a guideline that you applied, and therefore you know it to be correct. Now, let's go ahead and let's amp things up a little bit. I'm going to allot you 1 minute and 30 seconds to provide the answer. And here we go. Can you identify the first listed code? Jane, a 44-year-old yoga instructor, presents with the following diagnoses: hypertension, sinusitis, detached retina, and arthritis. The physician prescribed the patient with Zithromax for her sinuses and then referred her to specialists for all of her chronic conditions. Okay, coders, don't forget inventory. Select your first listed and apply all guidelines. Your time begins now. How did you do, coders? How did you do? All right, so if you got it correct, I'm just going to say go ahead and pat yourself on the back. But now I'm going to tell you if you did or not. All right, so what is the patient's first listed diagnosis? Well, the first thing I'm going to do is inventory, then select my first listed code, and I'm going to use that purple chart as a reference, and then review the guidelines. Step 1, inventory. We're going to inventory all of the diagnoses that the patient has or that's documented. And the doctor documented hypertension, sinusitis, detached retina, and arthritis. Next, I'm going to direct my attention to the chart because we have to determine of these 4 diagnoses, which one is first listed. Which one are we going to sequence first? Well, I'm going to stop at number 1. And the reason I always stop at number 1, and it reminds me, are there any signs and symptoms on that list? And I'm looking, there are no signs and symptoms. So I'm going to move on. I'm going to look at, I always go to 5. And the reason I go to 5, because 5 um is all it includes everything. Like 4 to me is embedded in 5. It's applicable to 5 no matter what. So 5, coexisting conditions. I'm told that I have to I have to code all documented conditions that coexist at the time of the visit. So all 4 coexist at the time of the visit because the doctor documented it. So that doesn't really tell me which one should be first listed. And then chronic, if I go to 4, it doesn't tell me either. It just says that you should report chronic diseases as many times as the patient receives treatment for them. So 4 and 5 don't really tell me how to select the first listed code. So number 6, it says when a patient has diagnostic or therapeutic services, then you code as the first listed code the chief reason for the encounter. That doesn't really tell me either. So now I'm going to tell you this is how you determine which diagnosis was chiefly treated, and it is the chief reason for the encounter. If you turn your attention to the documentation, it says the physician prescribed the patient with Zithromax for her sinuses, then referred her to specialists for all of her chronic conditions. So coders, based upon that documentation, which of the diagnoses was chiefly treated or addressed? Well, I can say one of them was addressed or chiefly treated more than the others, and that one diagnosis is sinusitis. Yes, sinusitis because the doctor prescribed Zithromax and then referred her to specialists for all of her diagnoses. So sinusitis was addressed more. It was more chiefly treated than the others. Thus, it is the first listed diagnosis. Okay, coders, how are you doing? Did that make sense? Type in the chat, let me know. I can see you, remember? Yes, let me know. And if you got that correct, outstanding. All right, we got another one. A 40-year-old college professor arrives to the physician's office with complaints of a chronic cough. The patient also has diabetes and hypertension. The physician examined the patient and diagnosed the patient with asthma. Okay, coders, what is the patient's first listed or primary diagnosis? Your time begins now. Okay, I know I ran over a little bit, but hopefully you got it correct. Inventory. What are the diagnoses, signs, and symptoms? Well, we have a chronic cough, diabetes, hypertension, and the physician diagnosed the patient with asthma. Now, we have to determine which of the diagnoses were chiefly addressed. But first, I'm going to stop at column 1, and it reminds me, do not code signs and symptoms integral or clinically related to a diagnosis. And I see a sign or a symptom on our inventory list, and we can eliminate it. But those signs and symptoms are important because they give you clues as to why the patient came to the doctor, and it could be helpful. So I'm going to eliminate chronic cough, and chronic cough is integral to asthma. It's integral to a diagnosis on our inventory list. So you could, as a coder, say that, that's pointing to the first listed code, but we always have to remember which diagnosis was chiefly addressed or treated. So the chief reason for the encounter will indeed be asthma. And we will code all documented conditions because they exist at the time of the encounter. How do we know they exist? Well, it's on our inventory list. Why is it on your inventory list? Because it's in the documentation. So it exists. They exist. So we will code them. All right. So the chief reason for the encounter is asthma because the patient came in with a chronic cough. That's why they came through the door. They didn't come in for diabetes treatment or hypertension treatment. They came in because of a cough. That is the chief complaint. And therefore, asthma is your first listed diagnosis. Okay, coders, how did you do? Let me know. If you got it correct, outstanding. But if you had an aha moment, that is priceless. All right, we got another exercise. Let's go. Paul went to the emergency department with complaints of dizziness, blurred vision, and left-sided weakness. He suffered a stroke in the past and believes he is having a stroke today. The ED physician performed a battery of tests, labs, and ordered an MRI. Then, after study, the physician diagnosed the patient with hypotension. What is the patient's first listed diagnosis? Okay, coders, your time begins now. All right, coders, how are you coming along? Yes, there is a minute and a half, and if you need more time, let me know. Let me know. All right, so I'll go ahead and highlight the keywords on this slide. Let's see how it works. So the patient complained of dizziness, blurred vision, left-sided weakness, had a stroke in the past, and he believes he's having a stroke today, and the doctor said, you have hypotension. All right, so let's go ahead and inventory all of those items. Now, let's focus our attention on determining the first listed diagnoses as well as the secondary. Well, it says do not code signs and symptoms integral or clinically related to a diagnosis on this chart. Well, this patient has dizziness, blurred vision, left-sided weakness. All of them are integral or related to hypotension and possibly history of a stroke. Possibly. Speaking of, number 5, we are directed to not code any resolved conditions. So if you had something in the past, it's in the past, unless it's pertinent, right? So if it's pertinent to the encounter, then you use history codes for past diagnoses. And in this case, this patient has a history of a stroke, and we need to determine, is that pertinent? Well, I'm going to say, yeah, it is, because those signs and symptoms are not only clinically related to hypotension, they are also clinically related to a stroke, and this patient could very well be having one. So the chief reason for the encounter in this case is going to be hypotension because the documentation says it. It says after study, the physician diagnosed the patient with hypotension. So hypotension, the doctor did a battery of tests, labs, and ordered an MRI and said, hey, you're not having a stroke. You have hypotension. So that is your first listed code. And we're going to also code that history of stroke because number 5, column 5 tells us to do it as well. All right. How are you coming along, coders? Let me know if this chart is helpful. And before I move on, I just want to shout you out and say outstanding if you got it correct. All right, let's move on to exercise 5. A 35-year-old executive who has a history of diabetes presents to his PCP with a complaint of easy fatigability and dyspnea on exertion. Even after 7 hours of sleep each night, he still feels run down and really has to push through the day. He admits to long hours with little outdoor sunlight. His lab results reveal a low iron count, and he was diagnosed with anemia. Lab results also reveal elevated blood sugar and A1C levels, and he increased the patient's insulin dosage. All right, coders, your task: code all codable diagnoses and symptoms and identify the first listed code. So don't provide the code, just provide the diagnosis in the chat. All right, so this one is a little more. So your time begins now. Okay, I gave you a couple more seconds. Let's do our due diligence. Now, this is a little more involved, all right? So we have to really be forensic. This patient has a history of diabetes, right? But he's coming in because he has fatigability, dyspnea on exertion, feels run down, and the lab results said, hey, you have a low iron count and you have anemia. Also, that lab result said you have elevated blood sugar and your A1C levels are high. So the doctor did some stuff like increasing the insulin. Now, let's go ahead and let's inventory. This is what an inventory of all that stuff looks like. Patient has diabetes, easy fatigability, dyspnea, rundown, low iron, anemia, and there you go. So we have to determine what is the chief reason for the encounter. We're going to stop at signs and symptoms. We are not going to code signs and symptoms integral to a diagnosis on this list. So we have easy fatigability. Is that related? We have first, let's identify the diagnoses, right? The diagnoses, there are two. We have diabetes and anemia, right? Yeah. So let's see if these signs and symptoms are integral to any of these illnesses or diagnoses. Easy fatigability? Yes, it's related to anemia and diabetes, or it can be. Dyspnea on exertion? Well, it's subjective, but it could be related to diabetes or anemia. I would say more anemia, but you never know. Feeling run down, anemia and or diabetes. It could. Low iron. Well, that's related to anemia. So we're going to get rid of these signs and symptoms. And that leaves us with diabetes and anemia. Which one was chiefly treated or addressed? That will determine the chief reason for the encounter. Which one was chiefly treated or addressed? Well, I'm going to go back to the documentation. It says its lab results reveal low iron count, right? So that lab result is pertinent to anemia. I'm going to check it off. Yes. Also, those lab results reveal elevated blood sugar. That's pertinent to diabetes. And A1C levels. That's also pertinent to diabetes, right? And it says that the doctor increased the patient's insulin dose. Not only did the doctor read the lab results, the doctor did something about it and increased the lab results. So you know what? Diabetes appears to be more chiefly treated. The doctor read 2 blood tests and increased the patient's insulin. So therefore, diabetes is your first listed code, and it is the chief reason for the encounter. Okay, coders, if you got that correct, outstanding. But if you had an aha moment, go ahead and shout aha in the chat. Are you getting this, coders? You know, we're really not using this chart so much, but we are learning how to look at the documentation to determine what is more chiefly treated. And hopefully, I hope you're getting that skill. Okay, coders, we got another exercise. Let's do it. Julie, A 39-year-old semi-professional dancer with the history of chronic ulcers arrives at her doctor's office with complaints of chest pains. The doctor ordered a cardiogram to rule out heart disease. What or which diagnoses would you code for this encounter, and what is the patient's first listed or primary diagnosis? Okay, coders, your time begins now. All right, coders, this is a prime example of why we read the last question first. It says, what is the patient's primary diagnosis? That's pretty much it. But it also is asking another question right above it. What or which diagnoses would you code for this encounter? So they pretty much want you to say all of the diagnoses as well. So sometimes just stopping at that one question might not be enough. So glance up and see if they're saying something else. You might not see this too often, but we got it here today. All right, so we're going to inventory. Inventory what? Chronic ulcers, chest pain. And here is an example of like a procedure, right? Yeah, but we're not going to we're not going to document it, but we did highlight it. And I'm going to stop at column 1. Column 1 says signs and symptoms. All right, do we have any signs and symptoms? Well, yeah, we got chest pain, right? But it says they may be principal when no diagnosis is present, right? Now, we do have a diagnosis on this list. We have chronic ulcers, and we also have chest pain. But let's just hold that off because we need to know if these chronic ulcers clinically related to the diagnosis, right? And I'm just going to say no because the doctor, if you look at the documentation, the doctor said, well, the doctor ordered a cardiogram to rule out heart disease. Didn't really make that connection, right? So if you don't know, you don't know. We're not clinicians. And typically, chronic ulcers would not be related to chest pain. But, if you have a hiatal, some ulcer in the upper region of your digestive system, you might very well have some chest pain, but the doctor didn't make the connection. So I'm going to leave it there, and I'm going to leave the chest pain there because it's not related. Now, let's figure out the chief reason for the encounter. Is there any other column that's pertinent? Well, it says uncertain diagnoses. Do not code them. Don't code uncertain diagnoses like rule out, likely, suspected, probable. So I'm going to get rid of number 3 based on that rule, right? Yeah. So between chronic ulcers and chest pain, what is the first listed code? Well, the patient arrives to the office with complaints of chest pain, right? And a cardiogram was ordered. So chest pain will be the reason for the encounter. It was most chiefly treated, and we will sequence chest pain first, followed by chronic ulcers. Okay, coders, how do you feel? Did you get that correct? If you did, outstanding. Outstanding, coders. All right, we have one more. Let's go. Joseph, the janitor, arrived at the ED via ambulance after falling and injuring his wrist at work. The physician completed a detailed history where the patient indicated that he has been experiencing headaches. The physician repaired the wrist fracture with a reduction procedure and then completed a full battery workup, including MRI for the patient's headaches. The physician diagnosed the patient with migraines and a wrist fracture. What is the patient's first listed or primary diagnosis? Okay, coders, your time begins now. All right. How do you feel, coders? How do you feel? You feel good about this one? Are you using your chart? Let me know. Type in the chat. Okay, now we have to inventory all diagnoses, signs, and symptoms. Well, this patient injured his wrist at work, right? And in that encounter, the patient said, "Hey, I've got some headaches." And the doctor did a full body workout up and said, "Hey, you have migraines." So our inventory: wrist injury, headaches, fractured wrist, and migraines. All right, coders, we're going to stop at number one. Do not code signs and symptoms integral or clinically related to a diagnosis. So let's get rid of wrist injury because it's related to the fractured wrist. Let's get rid of headaches because they are related to migraines. So that leaves us with fractured wrist. And we needed to determine what is the chief reason for the encounter or what was chiefly treated or addressed. Okay, so I'm going to look at my documentation and I like to see the chief complaint. The chief complaint is typically why they walked through the door. Why did this janitor walk through the door? Did he walk through the door because he had a wrist injury, or did he walk through the door because he had a headache? Which one? He walked through the door because he had a wrist injury. And if we get down to it, the patient had a procedure. That physician repaired the wrist fracture with a reduction procedure. Although the patient had a full battery workup and an MRI, the reason the patient walked through the door was the wrist injury, and the diagnosing of the migraines was incidental, and they had a surgical procedure. A reduction is considered a surgical procedure or treatment. So I would say a surgical procedure has more weight than a non-surgical procedure. A reduction sometimes requires anesthesia. Often it requires anesthesia, but it doesn't say whether it was open or closed. But nonetheless, this documentation is all that we have, and the fractured wrist will be the chief reason for the encounter, and the migraines, it will be sequenced next. All right, coders, how did you do? Let me know. Are you using this chart? If you're using this chart, you can find it in your MCG manual at the top, or you can find it under outpatient charts. And you don't use this chart forever. So a common question is, hey, can I use this on my exam? No, this chart is like training wheels. Use it until you don't need it. However, some people need it. They needed it. And for the CCS exams, they're documenting these charts in their manuals. Yeah, for referencing. Hey, they want to make sure it's right. I don't blame you. They want to be reminded. I don't blame them. All right, so let's go ahead and let's summarize. Great session on first listed code selection. You should pat yourselves on the back, coders. I know many of you had an aha moment. I just know it. And many of you may already know the material, and it was pretty much a review. And that was my intention, to give something to everyone. Now let's close our instruction on first listed code selection. This is what I want you to remember. Number one, remember to inventory all signs, symptoms, and sometimes procedures and treatment, and then eliminate what you need to eliminate. Number two, select the first listed code. You will need to determine the chief reason for the encounter, what was chiefly treated or addressed, and use the chart. It's your friend. And finally, apply all guidelines, because guidelines rule. They supersede all. Okay, here are my final thoughts for the week. Key takeaways. Well, we talked about mastering the Sequela, excludes and includes notes, and first listed code selection. These three topics, students tend to kind of struggle, so I decided to take them on head on. And you know what? I think you have proven that anything is possible. If you got through this session, you should know anything is possible. Now, next week, we're going to cover ICD-10-CM chapter specific guidelines. Now, we are still in section 1 of the guidelines, but this is C. You have A, B, and C. And this is what we're going to talk about next week. And chapter 1 is infectious diseases. Now, coders, I want to remind you to apply your knowledge. Never forget the fundamental or basic skills, such as looking up the code first in the index and verifying in the tabular list. Always keep that skill. And if you need to, return to the lectures, return to this playback. It will be in your, well, where is it going to be? It's going to be on the playlist. Yes, it'll be in the playlist, and you can access it from your syllabus, and we're going to review that very shortly. So review lectures, review what you need to do, the textbook, any of the readings, etc. Remember, practice is everything. All right? Now, speaking of homework, let's talk about that homework. Okay, you can find the homework assignments on your syllabus. And since we do not have a formal learning management system that manages all of your learning, we will use our website and the YouTube course page as a main information hub. So if you click on our website, www.amcicoding.com, well, you go to our website and click on the YouTube course and scroll down, you will find the syllabus. It says click here to download the syllabus. This syllabus will house everything. Let's take a look at the syllabus. This is your syllabus, and at the top, you'll see the required textbooks. We said 2025 preferred. However, if you cannot afford to get them, we get it. Do what you can, and we do suggest, like for instance, Carol Buck's step-by-step textbook. You can have 2023 through 2025, and then the AMCI MCG manual 2024 or 2025. Here are the links next to it, recommended links, but you can get your books wherever. You can even borrow them. It's up to you. You know your circumstance. Now, the course begins. The first 8 weeks will be ICD-10-CM, all related to ICD-10-CM, and then the second 8 weeks will be pertinent to CPT, HCPCS, and modifiers. Now, the homework due next week is found here. Now, this syllabus is not complete on purpose. It is not complete because we are guiding you through the 16 weeks. If you want to move ahead, you're going to have to wait for that homework. Now, after the 16 weeks, you can navigate this work independently. But right now, we're guiding you through. So let's review the homework due next week. Number 1, you are directed on this sheet to watch the prerequisites. And if you haven't already, go ahead and watch them. Many of you have. So parts 1, 2, and 3, go ahead. Now, if you've done it already, move on to number 2. Number 2, if you need to, you can find the playback here. Yes, you'll click that green button and it will be on this playlist. Number 3, you will need to read the official ICD-10-CM guidelines. Go ahead and download it if you don't have it. If you can't locate it, go ahead and download it. You'll need to read section 1A and B. Number 4, time to read your Bucks chapters. She's going to take you through the introduction of ICD-10-CM. So pretty much A and B guidelines and textbook only. Number 5, go ahead and watch first listed code selection for more, practice if you need it. So this is called How to Nail the Principal Diagnosis and also How to Select the first listed diagnosis. And it tells you to start at 1 hour, 37 minutes and 11 seconds. So if you want to watch the whole thing, you can, but principal diagnosis is only pertinent to inpatient or facility, and outpatient begins 1 hour, 37 minutes and 11 seconds. Then, number 6, you're directed to read Section 4 guidelines. These are the diagnostic coding and reporting guidelines for outpatient services. So go ahead and read it. And then you have a handout with the answers. So you do not hand it in. Coders, there are a lot of you. There's no way we could read all of those. So go ahead, do your work, and go ahead and check your work as well. And then 8, we will see you in class on next week. So We are asking you to take the survey, complete the survey. Let us know how we did tonight. Let us know because the survey helps us help you. All right. So, team, if you could put the survey in the chat, that would be amazing. Thank you. And thank you, coders. You all have done an amazing job. I just know it. I just know it because you don't have to be here. You are here because you want to become a medical coder. And remember, medical coding is more than just a skill, right? It's a craft, a career, it's a calling. And every code tells a story. It tells a story, coders. And remember, every story matters. And this journey will not be easy. You know it. You're self-studiers, so you know. But you also know that you are capable, strong, and you are meant to succeed. So coders, stay committed, stay curious, believe in yourself. And at AMCI, remember, we create forensic, accurate, certified, and ethical coders. We create the best of the best, and that includes you coders. Go study, go practice, and go be great. And last, but certainly not least, thank you, team. Thank you, AMCI Amazing Team. You are the best. Until next time.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI. AMCI. AMCI.